My name is Jeff Zwicker. I am a translational hematologist at Beth Israel Deaconess Medical Center, and my research mainly focuses on thrombotic disorders, especially cancer-associated thrombosis. So this was a bench-to-bedside project that initially started a few years back in the Fury laboratory, where they identified that targeting a protein called protein disulfide isomerase with an antibody could reduce platelet aggregation and fibrin generation in an animal model of thrombosis. That in fact, if you were to target this protein disulfide isomerase, you could have a total absence of clot formation following a vascular injury. Protein disulfide isomerase is secreted by platelets and endothelial cells, and in fact regulates protein function either by disulfide bond reduction, isomerization, or oxidation. So without a known small molecule inhibitor of PDI, the Flamenhoff group at Beth Israel did a high throughput small molecule screen and identified quercetin flavonoids as inhibitors of PDI activity. And this is interesting because these quercetin flavonoids are commonly present in fruits and vegetables and wines, and have been shown, at least in epidemiologic studies, to prevent potentially cardiovascular complications. So we decided to take this quercetin flavonoids and actually look in humans whether or not the effect that we see in animal models could be observed in humans. So we did some initial pharmacokinetic, pharmacodynamic studies. In fact, we're able to demonstrate that isoquercetin, in fact, could inhibit PDI activity in human plasma, which then led to the initiation of this phase 2 study. So this phase 2 study, we took advanced cancer patients at high risk for thrombosis. They all had either advanced pancreatic, non-small cell lung cancer, or colorectal cancer, who were receiving chemotherapy. All patients had to be initiated within 4 weeks of initiating chemotherapy and were scheduled to receive either 500 milligrams of isoquercetin, which was the first cohort, or 1,000 milligrams of isoquercetin daily for 2 months. So we initially enrolled a targeted 30 patients at the initial dosing cohort of 500 milligrams of isoquercetin, just to first make sure that in fact it was well tolerated, with the primary endpoint being a reduction in D-dimer values. And then if that was well tolerated, we would proceed with a 1,000 milligram cohort of similar design. And all patients had baseline blood draws at day 0, as well as the end of study, as well as an end of study ultrasound to in fact ensure there was not asymptomatic deep vein thrombosis. What we showed was that the 500 milligram cohort, it was well tolerated. We did not see any bleeding. However, we did not see a reduction in plasma D-dimers, which was the primary endpoint of the study. In the second cohort at 1,000 milligrams, we did see a significant reduction in D-dimer values, with all but 4 individuals having a significant reduction in D-dimer. Along with a reduction in D-dimer, we in fact also saw a decrease in platelet-dependent thrombin generation, as well as evidence of PDI inhibitory activity following ingestion of isoquercetin. Notably, in neither the 500 milligram cohort or the 1,000 milligram cohort did we in fact see any venous thromboembolic events. So there was no proximal deep vein thrombosis, no pulmonary emboli. However, there were a couple line-associated clots, which were not considered part of the primary endpoint. Also notably, we did not see a single major hemorrhagic event in either cohort. The absence of thrombosis was an unexpected finding. In similar cohorts, event rates typically are 10, 20, 30%. And in fact, in a previously published study that we performed, the same exact inclusion-exclusion criteria and monitoring, we had an event rate of over 20% at 2 months. Such the absence of thrombosis is an interesting and provocative finding of the study, as is an absence of major hemorrhage. The role of PDI in thrombus formation continues to be explored, but what is known is that following platelet activation or endothelial activation, in fact, PDI is secreted. And how PDI in fact regulates coagulation is still a bit of a black box. However, we do know that it can bind back to the surface of cells, including platelets and endothelial cells, and can regulate the activity of certain procoagulant proteins, probably the best of which was characterized by Dr. Fury's lab as vitronectin. However, the panel of proteins that PDI regulates, I think, is an area that will be continued to be explored in the near future.